Welcome everyone. I'd like to begin by acknowledging the traditional owners of the land on which we meet today. I would also like to pay my respects to elders past, present and emerging. Well, good afternoon everyone and welcome to the August FightMND Scientific Seminar. My name is Sarah Bennett and I'm the Senior Research Coordinator at FightMND. We hold these seminars monthly on the last Tuesday of each month, and last month in July we heard from Professor Claire Parrish and Dr. Cam Hunt from the Florey Institute in Melbourne. They spoke to us about the stem cell models they're creating to study upper motor neurons and the neurovasculature. If you're interested in this presentation and weren't able to join us live, a recording is now available on our website if you'd like to catch up at a convenient time. So following the talk today, we are leaving plenty of time for discussion and questions. So if you'd like to ask anything, please feel free to use the reaction button to raise your hand, and one of our team will enable your microphone and camera and let you know to ask your question. Alternatively, you can also type your question into the chat where our team will be monitoring and read out questions on your behalf. Please note that the chat function is only enabled if you are using the app-based version of Teams and unfortunately doesn't work if you're on the web-based version. Please ensure you introduce yourself and where you're from before asking your questions so we can all get to know each other. We are recording today's presentation for anyone not able to attend live at the moment. So now to our presentation for today. We are fortunate enough today to be joined by two researchers in the MND care space to talk about a collaborative project. Associate Professor Anne Hogden is the Program Director for the Masters of Health Leadership and Management with the School of Population Health, Faculty of Medicine and Health at the University of New South Wales. Anne's background in speech pathology has meant deep experience in the healthcare space, leading to her current research interests in development and implementation of decision tools for people living with MND. Dr. Karen Hutchinson is a Senior Research Fellow at the School of Population Health at the University of New South Wales, specialising in MND health services research. A physiotherapist, her research focuses on integrated models of care, co-design, health service mapping, equitable person and family-centred care, as well as implementation research and practice and workforce roles and responsibilities. It's really a pleasure to have you both join us here today, and we're really looking forward to hearing your presentation. Over to you.
I'm Anne, and I'll kick off for Karen and I. So thanks everyone for this opportunity to come and talk to you today to talk about getting towards fairer MND care. And so you can see from the title, we're talking about the inequities that have come up through the research projects that we'll be talking about and the solutions that are then emerging from those projects. So all in all, we're touching on 6 different projects that have been funded by FightMND. So we've jam-packed quite a lot in there, but hopefully we'll explain it well enough so it makes sense. But again, plenty of time for questions at the end. Okay, so what we'll do is we'll start off talking about why equitable and excellent care in MND matter, and then we'll go to building the awareness and understanding of MND care and the challenges that we're faced in Australia. Then we'll move to the current research and solutions that we're finding across the different projects across Australia. And then what comes next, what's happening next. And just an acknowledgement here that a lot of the diagrams, but not all, have been generated using ChatGPT edu. Just so you know, we're not artistic. Okay, so this is when we talk about equitable care. Now, we often use the words equal and equitable, and they're not the same thing. And so the diagram here helps to explain that, what care looks like in reality, what equality would mean, where everybody's standing on the same box, and what equity would mean, because it gives people the same access. So even though they're all standing on different boxes, they can all see in the diagram, they can see that same playing field. So it's about people receiving the right care at the right time, that the care is appropriate to their needs and circumstances, and that people are not disadvantaged according to your postcode, where you live, your age, culture, or your income, or your ability to communicate. And so family and providers are not left to navigate the fragmented systems of care by themselves. And we have a joint approach, and people have a fair opportunity to achieve the best possible quality of life with that care. Okay.
Oh, sorry.
Karen's navigating, I'm talking.
Oh, sorry.
All right. So The purpose of this slide is just to talk about how excellence is actually experienced, not just delivered. It's something that you need to feel for yourself. So when you're looking at the care that you're having, that it has a lot of these aspects to it and you're experiencing them. It's not being just given to you. That's a full-on experience. And that's why excellence matters. And so here is where we talk about the timely access and responsiveness, that you can access the care when you need, and that your needs are anticipated and not just responded to, that there is continuity and expertise and evidence basing the care that you are receiving from your healthcare providers. And you see here from the rest of them, the whole person and family are incorporated into that care, and that there is enablement and quality of life coming out of that. And also it includes psychological safety and preparedness. So excellence should not just be what's achieved through individual actions, but through collective effort and from team-based care. And you can see that communication and coordination. So the little black dots, that's where it's threaded through each of those aspects there. I hope that makes sense. It's quite a lot to pack into one slide. All right, so what does MND care look like in Australia, and what are the challenges and inequities faced, and why do they exist? And so Karen's going to talk about understanding the context where care is accessed and delivered and how important that is.
I apologise for my blip there, and my animation didn't work on that other slide, so apologies for that. So this slide illustrates the complexity and a bit of fragmentation across care. So we can see that we have the red dots are the services, the MND specific services that we have across Australia. And as you can see, they are mainly clustered around cities across most of the country. And there are quite large gaps where there are no specialist services. We've been looking at doing some service mapping. So we've mapped 21 health-related MND services across Australia and gathered as much information as we can across these services. So just to sort of get a bit of understanding, we asked the MND associations how many people they had registered across each of the associations across the country. And what we found was there was a total of 2,090 people that were registered. We're not aware of how many are maybe registered with different organisations. And then what we then had also asked in our service mapping were how many people were registered within the MND services that we have listed here. And what we found that there was about 1,690 estimated. Now that was probably higher estimation rather than on the low side. So when people gave me between 40 to 50, I used 50. So as you can see that then there is a bit of a discrepancy in the numbers that are actually accessing these services. But again, this was only from 17 of the services, and I'm still waiting for some data from some of the other services that we have outlined here. Also, what we have to remember that across Australia, we have got 31 primary health networks. We have 64 health districts or networks and services, because the terminology is different across the country. So and although what we found in the service mapping is that we have multiple health and social care systems, funding streams, and governance arrangements across the country, and there is no consistent way in which MND care is organised or delivered. So there are huge variations. Although most of the services outlined here can access neurology and palliative care, the availability of allied health, psychology and care coordination varies substantially. even where a care coordinator role exists, employment arrangements and access to medical records can limit what care coordinators can do. So we've got geographical coverage across, differs across all the different areas. And also people may experience different pathways to care, depending on where they live and where the services can be accessed. So currently, we really are just trying to build the foundations of understanding of what services look like across Australia. And it makes it quite difficult to identify duplications, gaps in care, and where people are falling through the gaps because of the access to data across the country. So this is a very busy slide here, and but it highlights the complexity. And across all of these systems, what people have is that dependence on relational care. So trusting relationships help people to engage with services and access the care that they need. So a lot of the work that is going on is being, people are being supported by individuals, often not the system themselves, to access care. We have got multiple services. We've got people living in rather rural communities. We've got huge inequities across funding and eligibility for funding. We've got information and communication is fragmented reportedly across the country. And we have got changing needs over time. So we know that some people's progression can be quite rapid. So the impact of this complexity that people have identified is it's hard to navigate the system, duplication and delays, care gaps and inconsistent experiences, variable access and outcomes, and increased burden on people and the families. But we've also identified there's amazing people out there providing care. So there's identified excellence in MND care. There's innovative practices. There's champions and leaders looking at different ways of practice. We've got really strong relational care. There's so many people are passionate, motivated, and want to help make a difference. And there is a good community around that have an understanding of MND. But as I've already highlighted, services available vary greatly in the workforce, the funding, the governance, scope of practice, coordination and continuity of care, the way people communicate and share information, referral and escalation pathways, and also the research that's being conducted. So this slide here highlights that the pathway to accessing equitable MND care is not a single event. So availability does not guarantee access. A service may exist, but still be unaffordable, difficult to access, too slow, inappropriate, poorly delivered, or disconnected from other care. And the Levesque framework helps us identify these dimensions of access from the health and people using the services from their context. But timeliness and the time-related elements such as travel are not really reflected in this framework, which I think is really important in MND care and warrants greater emphasis. So for people living with MND, delays can have serious consequences. So timeliness must be considered alongside affordability, acceptability, appropriateness, and the quality of the care. We also need to recognise the essential contribution of family carers and ensure that people with lived experience have a genuine role in shaping and delivering the care that they receive. So care is a collective responsibility. So we need to look at stop filling or plugging gaps, and in doing so, adding to the complexity of MND care. We know that people want to make a difference. We know people want to make things easier for people, but sometimes just adding more services without really understanding the context can make everything much more complex. What we do need is a stronger infrastructure, a system that uses the resources and workforce we already have more efficiently and effectively, while creating care that is more sustainable, connected, and coordinated. At the moment, too much relies on individual people going above and beyond. We hear goodwill often mentioned in this research. Passion and motivation and goodwill are incredibly important, but they are not a sustainable way to deliver care. It creates frustration, adds burden, and contribute to burnout. So we need the right resources, workforce, and systems to better support people with MND and those delivering their care. To do that, we need to understand how care works. We need to better understand the needs of both people receiving care and those delivering it. And this is hopefully what this research is helping to raise awareness. So the next part that we're going to look at now is the current research building awareness and addressing gaps in MND care. And a quote from our research from a healthcare professional is, how can we make it care better or as good as possible? And now over to Anne.
Thanks, Karen. And when we sort of, just to summarise those inequities or problem areas that we found, when Karen showed you the map and you could see that the MND specialist services were all clustered around metropolitan areas, so the state capitals, for example. But as you may be aware, a lot of the people who live with MND live nowhere near a capital city. So for me, that's something that just summarises the problem in many ways. So solutions, where are we heading? What are we going to do to fix these problems? So we'll be touching on a couple of projects that are producing things that help to bridge these inequities. So the first one is, this is the project that I've been leading, so the decision-making, and we're talking about support for decision-making across two different projects. So with the project that I've been leading, it's been about developing decision tools. So this project is coming close to its end, and in theory, this will be the 6 tools that are up and available for people once we finally launched this website. So we did a bit of a voting process with the stakeholders in our project to see what were the tools that were required to tackle the thorny decisions in MND care. And we found that it was things like diagnostic testing and predictive testing for family members, looking at PEG or gastrostomy to assist with eating and drinking, then the use of NIV to help with breathing. And the other two that were added to this from the original 3 tools that we developed many years ago, we're looking at advanced care planning. So looking particularly at the advanced care directives, how they differ from state to state, and just understanding what people might need to do if they want to decide to go ahead with completing an advanced care plan. Also, we're looking at palliative and end-of-life care. So they're the 2 new tools that I hope will be available for you at the end of this year. So just going on to the next slide. So another project, this one's conducted by Marnie Greco and her wonderful team in Melbourne, and looking in part at the barriers, what stops people from accessing NIV. So where are the barriers there for Australians living with MND who could benefit from NIV? And Marnie, I know, is attending this, so any questions at the end, we can turn to Marnie, but this is just me giving a little bit of a spruik about this project. So there are resources that are going to be launched in September, Friday the 11th, at the Adelaide Convention Centre as part of the MND Australia conference. There's some videos and there's some question guides, and that QR code there down the bottom of the image there, that will work if you want to know more about this project there. So that's giving more decision support, but in particular for NIV, and what are the things you need to consider before you make your decision to use NIV. Okay, we might go to the next one. So that's back to Karen. So that was decision support.
Yeah, So this is a project that Anne is actually leading as well. And this study is a national study that some of you may have already heard about. So it's called Bridging Health Equity Gaps for Australians with MND. And this study has demonstrated the need for stronger evidence about what influences access to MND care across Australia. So we have held online surveys, and we had 51 people with lived experience, and then we had 53 healthcare providers and social care providers and researchers. So this study, this survey was a really just sort of testing the waters, really, and it was identified that respondents really heavily rely on mainstream and community-based services in the public health system, their GPs and not-for-profit organisations, so the MND organisations and associations. And most of the people with lived experiences accessed diagnostic, therapy and symptom management services, and psychosocial support was a significant gap, and is definitely an area that needs further looking into. The main barriers for people with lived experience in accessing care was the limited local availability of healthcare providers, the limited knowledge of MND amongst the community, and also the travel, as Anne highlighted again, is that where a lot of those specialist services are is not sort of evenly distributed around Australia, but also where those people live, we're not really aware of, you know, we know there are some clusters of people that are not in those city areas. And then the care costs. And we are all very aware of the inequities in funding across the NDIS and the My Aged Care sector. The care providers identified in fragmented governance structures, poor communication between the specialist services and the local community, and uncertainty about where to find MND information and support. Then we held focus groups from across 11 of those in total with 66 people. And of course, really importantly, we had 27 of those participants were from the lived experience group. And across both the survey and the focus groups, we had people from all across Australia, which included the territories as well. So very excited to have particularly the Northern Territory join us in this research. And we really delved a lot more deeply into the system level problems, including duplications in care, inefficiencies, variations between jurisdictions. So some people actually travel to different states and territories to get different care. And including the roles and responsibilities of the different health and social care providers. There was who does what, when, and where. So people were a bit unsure as to who they needed to contact. So these findings sort of highlight the stronger network. We need that stronger networks across the MND community and better communication and collaboration across the problem solving to help improve access and continuity of care. So we're also doing the mapping of MND services, and so far, as I already highlighted in the other the slide with the map, we've gathered data from 21 of the services. And we are now currently, we've held a workshop, and we've held one to help us prioritise the challenges that we have identified, and 3 more plan to identify solutions and then develop a roadmap for each of the solutions that we have identified. So just on the right, this is, I think this is a really good slide. It's telling everybody about what the process is. We get all this data, we try to sort it out, we try to arrange it in ways that we can sort of communicate in a better understanding. Presenting it visually can really help, but we feel that explaining it with a story is a really important way to help with understanding. So we've been listening to personal stories. So this was one former carer who highlighted some of these many aspects of their care journey and some of the roadblocks or the areas that they felt really challenging. So from the point of diagnosis, I don't feel it was made clear the path to connect with supports. I feel there was unnecessary delay. The process of finding support feels like feeling my way in the dark. And I don't feel like I have a single point of contact to help coordinate the numerous people supporting me. And the multidisciplinary component, but not effectively bound into a team by a single coach or coordinator. So highlighting sort of the many different people that is involved. And this was one person's quote. So here we have a couple of personas that we've been using to better understand experiences, because when we're communicating these inequities, not everyone has got experiences of inequities of care. Some people live in city areas, some people live, you know, in rural. So to sort of make sure that we have that shared understanding, we've developed these personas, and one is called Jade, who's a healthcare professional, and then George is a person living with MND. So that using these is a hypothetical representation of both care receivers and deliverers, and it can be help to inform our and gather our data from the research. So what we used these for the focus groups, and then since for the workshop we adapted that, and this is all based on the information that we have been gathering in our research. So these are all things that people have highlighted in the focus groups and in the surveys. So, you know, what we've used this for is what stands out to you about this person's experience. Where do you see inequity in the experience of MND care? And what might be different for someone living in different circumstances? So within the workshop, we really highlighted that. We had one person who highlighted that they had access to this great multidisciplinary team. They saw all the allied healthcare professionals. They didn't have to travel far. Whereas another person highlighted the fact that they got diagnosed, they then lived 7 hours away from that city, and they had no services at all. So it really highlights that huge discrepancy, and people didn't know anything about MND. So these are some of the, there's some challenges here that we have identified that, and for equitable care, we need to, and we've narrowed it down to 8 challenges. And as people who have been part of these this process have really highlighted that it's really hard to prioritize solutions or prioritize the challenges to then explore the solutions. So in workshop 1, we started off with 11 challenges, and we explored 3 questions. What is the problem? Why does it occur? And why does it matter? So then, but we know that these are all interconnected. And we really are now trying to, the next stage will be looking at potential solutions. So some of the things that have been coming out from our research with regards to timely diagnosis and entry into MND care is that everyone on a referral should be referred to the MND associations at diagnosis. So wherever they get diagnosed, that there should be some way that that person then knows that these people, this is what we do. And one of the ways that has been started to be explored a little bit more is through health pathways, which are, we know that there are 19 MND focused health pathways across the 31 primary health networks in Australia. And, you know, this is to help support GPs and other healthcare professionals in recognising signs and symptoms of MND and inform them of the diagnosis and journey and what information people need when they're diagnosed. So these are some things that are people have discussed in our research as being potential solutions. We've also got, you know, to do with the communication, coordinated and connected care, is how do we share that information? So talking about shared care plans, we know that that's used in some other areas, and there are examples of people doing this across the country. But it's not nationwide. And nominating a single point of contact, how that would look, because people have discussed that maybe there isn't just that one single point of contact. But again, these are all the things that we will be discussing. And then telehealth is being seen as an enabler to ensuring that people are accessing multidisciplinary care, that people are gaining knowledge and expertise, and that there is that support for the people that are living with MND, but also the healthcare professionals and support workers. So some of these, as I've already mentioned, approaches are already being used in Australia. We don't always need to reinvent the wheel, but we can actually build and sort of look at these great practices that are already there and see how we can maybe make these more consistently available across the country. There's also looking at what are the core elements of a multidisciplinary team is another area that's up for discussion. So this is over to Anne now. This is the next project.
It's me. Thanks, Karen. Okay, so when we talk about understanding and optimising MND care, we're also talking now about another project that looks at the roles of the care coordinators in the Australian healthcare, the MND clinics. And so by this, we mean clinicians who are employed within the clinic to coordinate care for people with MND and their families coming into the clinic. So lots of different aspects of that in this project. So defining the role of the care coordinators has not been easy because we find there are many professions, many organisations that overlap into that space. And so looking at what a clinic coordinator is has been one of the biggest challenges of the project. And so to get down to finding out what the definition should be and what clinic coordinators do or could do, there was 158 people who took a survey, and then 18 care coordinators were contacted and 11 of those were interviewed. What came out of that is to say that not everybody is getting access to a care coordinator as part of their MND treatment, and then which makes perfect sense when we go back to that map and see where the clinics are located, where people potentially live, and for a clinic to actually have someone who's employed to do that coordination role, it's just an extra hurdle for some of the health services delivering care to people with MND. And so the working conditions of the care coordinators varied. So they're all called a whole range of titles. I can't remember how many it was.
Yeah, well, there was only, I think, about 3 or 4 that actually had MND in.
Oh, MND, they were, yes. But yeah, a huge range of titles. So when you consider yourself an MND care coordinator, but the word care or coordination or MND is not actually in your title, then that becomes a little bit opaque to people trying to access care. So role titles, the caseloads, the hours they worked, the team they worked with, and then also how they were funded, how their positions were funded, and whether they were acknowledged by their healthcare services to be an MND clinic care coordinator, or if it was something that was just tacked onto their normal role within the MND service. So What's the start for? These are the good things. Yep, these are the good things. Okay, if it's got to start, it's a good thing. So there is support for the role and recognition of its impact. And so that's part of the study to understand what the impact is of these care coordinator positions. And the quotes there, they are the glue that helps keep the service together. So yes, they're coordinating, there's care, they're pulling it all together for people. But the challenges are the coordination roles across a range of services and the lack of role clarity. And 50% of the care coordinators we spoke to said the hours were not reflected in their position description. So as I said before, they're not technically employed to do that care coordinator role. It's just something that's been absorbed up into the role they do because of the need for coordination of care. And so the quote there says, our clinic and probably others as well, they're passionate. The people who are doing this care coordination within the clinics love doing this and they see it as a need. And so they're running with it themselves. So there's no protected funding and for those roles in particular. So that's, a potential solution to what we're looking for with solving equity problems, but it brings with it its own number of issues there. So that's one of Karen's projects that she's running. So.
Yes, thank you. And so this is just, it's a quote that I think this is a really great quote because it highlights some of the roles and responsibilities of MND care coordinators to ensure that people receive timely and appropriate person-centred care. So this quote is related to a situation where the care coordinator was not around and they were on leave and the person was going in for a specific procedure and they didn't have that advocate in the health system. And they just didn't know that this procedure should have only taken a couple of days and they would have been in hospital for that time. And because they didn't have that person, they were in for 2 weeks. So this care coordinator really wanted to highlight how much that they advocate, how much that they are the one that opens the doors, that they find what needs to happen, and building those connections to make sure that those that the way care is delivered and those sort of procedures are done in a much more effective and timely way. And so with the care coordinator research, we are planning to do some co-design workshops to actually help look at how can we build a framework of what a care coordinator role is, their core responsibilities, what their training needs are, and how, and hopefully help to sort of understand the role much better so that we can build more sustainability, improve resources for this largely underfunded position.
Okay, so my turn again. So just flicking to another project that Samar Allen has been running on looking at end-of-life care and how this overlaps with our inequity projects because you can sort of see once you start looking at end-of-life care, where it's happening, where it's not happening, and how well palliative care is involved with that, you start to see the inequities of the services given. So this slide's just to say that Samar held an in-person forum in Melbourne earlier this month. There were, I think it was about 80 attendees. Yeah. And Samar's on the call as well. So if you have specific questions about this, I'm sure she can answer them for you. And I've just listed, this is not all of the attendees, but some of the groups that the attendees came from to show that, again, there was national representation on this, just as there has been on all of the other projects that we've spoken about there from and great to see that there were from the funding bodies, from government agencies and clinicians and GPs. Great to have GPs involved and our people with MND and their carers and our researchers as well. So the outcome of that, this is just something I've pulled together from the preliminary data that was gathered at this in-person forum. Well, it was, wonderful to see everybody coming together and being able to talk to each other directly instead of through a screen, as it so often is. And so the 9 themes that came out of this that showed the importance of end-of-life care and what needed to be changed. So moving from fragmented and reactive care to integrated, proactive and coordinated care to help reduce those inequities, and starting with that palliative approach to care from diagnosis in MND, rather than people being sent to palliative care at the end of their lives. Having that care coordination and clear pathways, consistent coordination coming through their MND journey, rather than just being tacked on at the end. And that was one thing we could do to genuinely ensure that their care was integrated and that there was good information and care and planning that moves with the person with MND. Because so often we know with services, they don't always speak well to each other. But if the person with MND and their family are holders of that information and are participating in their care planning, then the information travels with them. So that's a really helpful way to approach it. Just looking at the workforce and the workforce capability outside of the specialist MND services to get a much better reach across the country. Education that's visible, accessible and role appropriate. And so that's what we see with some of the MND Australia resources like MND Connect and other things that are, and they're not held by a state organisation or by a government organisation or by a particular clinic. Like the decision support tools like Marnie's NIV support resources that are coming out of these projects, these are all available independently and nationally. So they're not reliant on a particular service or state. And so you can see the importance of communication, as Karen's talked about, relational skills and making sure that family carers are included and that there is equity across the country and across state jurisdictions, which is always a big boundary, let alone within the states, as Karen's mentioned before. So family and person-centred care across the whole journey from diagnosis, living with MND and end of life and bereavement. So the whole spectrum. Okay, this is me too, yep. So transparency is key. What can we do better together? So by strengthening our networks and building collaborations and working as partners, not just within the research field, but in the MND care services, clinics, involving people living with MND and their families, so that that MND network or ecosystem, if you like, is much better connected. So people get to talk to each other about what's going on, and that the excellence of care is transparent, along with some of the issues that people are experiencing. So people are much more aware of what's going on because it's done in partnership. And that's one way we work towards ensuring fairer MND care across the board. All right, and I think I have this one last one. So this is what a coordinated MND care journey might look like. And again, I've pulled this diagram together from the data that came out of Samar's End of Life Care Forum. And it's just saying that, we travel from diagnosis into bereavement support across the navigation of care, introducing that early palliative approach, using much more coordinated interdisciplinary care, whether it's in a specialised clinic or in a clinic where the providers have skilled up to treat people living with MND, where the planning and care is shared and that the workforce are skilled and supported to deliver that care. And we know that there's resources available already with MND Australia and within the state associations as well to help skill up the people who work in general services who very rarely see people living with MND, but need those skills to be able to be responsive to their needs. And so the responsiveness and timeliness of the equipment and the funding to receive that equipment and to then progress into end-of-life care and then bereavement support for the carers afterwards. And so what we call the cross-cutting elements that go across all of these aspects in the care journey. Sorry, I'm just going to duck here. So we've got equity. So we know that equity is important and that there is support for carers, and that the timeliness of the response of services and shared information to give a sustainable workforce and sustainable funding for that workforce. It's probably one of the harder nuts to crack on this, and that there is accountability across the board between services, care providers, and the people receiving care and going across there. So again, it's preliminary pull together for this project, but it's looking like that's going to be how it's shaping up. And again, the focus is on the person living with MND and their families and being at the centre of that care journey. All right, so we've talked a lot about 5 or so different projects, and this is the 6th one. So all the research that we've spoken about and plenty of other research that's going on across the country is pulling data out that is going to assist the development of the Australian MND guideline. And it's a wonderful project that people living with MND and their families campaigned for many, many years, and one of the great successes that they've had in getting this project up and running. And so the guideline looks at improving consistency and quality of MND care across the country, and that there is support for healthcare professionals and clear clinical guidance to help families better understand and navigate the care that they need to use and approach, and to reduce the disparities in access to the services and support. So those 4 aspects are for the guideline in its own, but you can see how all the other projects are now feeding into that. So the next steps is just getting that information together and then allowing that to inform the guideline that is produced for people living with MND. And that's us in a nutshell. So I think we've got nearly 15 minutes for questions.
Thanks,
I'll just stop sharing.
Yeah. Thanks, Anne and Karen. So for everyone on the call, if you do have a question, feel free to pop it into either raise your hand or pop it into the Q&A box on the top left hand of your screen or in the chat box. So Karen, and it's nice to see that all the research is all feeding into the guideline project. I do have a couple of questions for you. One is around telehealth. So I think a lot of the inequity we see for people living in regional, rural, remote areas is they can't access the healthcare professionals, they can't get to them. And telehealth has helped with some of the access. But when I was quickly scanning the persona thing that you had up, I think one of the things was telehealth is still a challenge. Can you comment on what some of the challenges for telehealth are for people living with MND?
Well, I think from what I've we've been gathering from our research is that people do largely prefer that in-person support or being seen in person. And that's the people with MND and their families and the healthcare providers. So there's still that that perception that, in person is maybe better. There are quite a few services that have telehealth, not necessarily used consistently. Some use it better than others. There is a particular service that I've just spoken to just recently who are in a regional rural area, and they actually source healthcare providers wherever that person is to come into the person's home while they are doing the telehealth appointment, so that they've actually got that support in there when they're doing any telehealth sessions. So there is somebody having a healthcare professional maybe being part of that discussions. And I think that seems to sort of work quite well, because they can actually see and do things for them. And I think one of the things that people said is that some care can be provided via telehealth, and some it's much harder to do. What seems to work quite well is that if there is a telehealth approach from, say, a service that is focusing on MND, and maybe, say, for example, the physiotherapist is there at the same time and they work together, that can work. That seems to be deemed as really positive. So it's very much what the capacity of the service is to do telehealth, and we know that rural and regional areas are often better at that because that's what they use a lot more. But I'm not so sure that the services within the cities are all geared up for that type of approach. So it's quite variable, but I think that's something that really needs to be looked at, is how it's accessed and a better platforms and better collaboration across the way that it's delivered.
Yeah, and I'll just add on to that too, Minion. I think that a lot of the when we look at telehealth, we often look at it from the service provider's perspective. But it'd be really good to see a bit of a shift in that, to see what is it that people with MND and their families want from telehealth, and can that shape the service that is offered? Because often maybe the clinic itself may not control how telehealth is offered in their healthcare organisation. There's a whole lot of internal things, and of course the government funding for telehealth that changed in the post-COVID era as well. So a few things to think about there.
Yeah, and Phil Camden had a comment. I think he's quoting someone, potentially Phil, but he says that I really like telehealth as part of the mix, but I don't think it's the answer on its own. It's great for reducing travel and keeping in touch, but it can't replace the hands-on diagnosis, equipment fitting, or physical assessment people need. And he also says that telehealth is a bridge and not a destination.
Good point, Bill.
Good point, as always, Billy. Gethin, you have a question?
Yep. Hey, Karen and Anne.
Hi, Gethin.
Question around, there seems quite a discrepancy perhaps in the capture of MND patients between state to state, and who's actually getting services, who's booked in with the associations. So with the advent of hopefully MND becoming a notifiable disease in New South Wales, how much of a difference do you think that could make? Is that going to be maybe a bit of a game changer to know where the services should go, where people are regionally versus urban, et cetera, et cetera? Just wondering if you could comment on that and how it might hopefully increase services. And
yeah, potentially. Yeah, it could be a game changer, because if then the GPs are reporting, that can make a whole lot of difference.
And I think from having, a service that is in Western New South Wales, they have 19 people with MND on their, which is 46% of the clients in their team, and so that is using their services, which is a neuroprogressive team. So that's quite, and they are spread, and Western New South Wales is the size of Germany. So we have to remember that these are 19 people scattered over a very large area, and yes, accessing care and support is very challenging, and often in those rural areas there is often a lack of GPs as well. So this is what we have to sort of overcome, and they might be their main medical provider in that area. So I think it would be really it is really important that people really understand where people are living, so that the services can adapt and respond to those which some people are calling those clusters across the country.
thank you.
I've got another question, which is around I guess two questions around care coordination. The first one is for the MND care coordinator project. I think the outcomes is trying to build a framework for what a care coordinator could look like. What do you think the next steps are from that project after you've built that framework?
I think one of the things that I suppose is really needs to be understood better is how they fit within the other care coordinator roles, because we are finding that there has been real confusion across what people do and where people are employed by. That's why we had to do this MND care coordinator is employed by health, because we know that there are care navigators, there are clinical liaisons, there's MND advisors, there's MND coordinators of support, and people were actually, with lived experience, were actually calling up their care coordinator going, is it you that I'm actually completing this survey about? So people are finding that their experiences as well of what a care coordinator does And there's a lot of assumptions, I think, as well within who does what. So I've had people say, no, that's my role. And they're going, no, well, I do that. And so we've got this is where we have some duplications and some inefficiencies. And, you know, everybody wants to be making a difference. So that's where I think is that we need to look, you know, wider as to what that care coordinator role does and what different people are doing, so that we can work much better together rather than feeling that the person with MND and their families feeling overwhelmed by having so many different people. They're not quite sure who they go to for what. But the other thing is hopefully having this framework, and I know internationally there's nothing really being done much about this, and other people are looking to this research as well to sort of help we can sort of work together and sort of inform this role. So you know, but you know, we have to understand the Australian context particularly for it, that you know, that these roles are actually practicing in, and also look at it that people with a healthcare background don't necessarily have experience in care coordination per se. They might have some, but it is a role in itself. And I think we need to understand that sometimes people need better maybe buddy systems or training to sort of to work in that role. It's not just assumed that because you've been a healthcare professional that you know about care coordination, and everybody is having to, we need systems in place, because a lot of worry across care coordinators are that if they retire, who's going to do their job, because they have developed their own connections, their links. So we want to sort of make that more sustainable.
Yeah.
Sorry, that was long-winded.
I think Samar is saying the same thing, where we do need to create a coordinated pathway around the person living with MND and their family. I guess my second question, I don't know if this is a right question or not, but when it comes to care coordination, who do you think that role should sit with at the end of the day? Because you have so many different roles around coordinating care. You've got some in the healthcare system, you've got some in the community. Who do you think the care coordinator role should be sitting with to make someone's MND journey a lot easier? Because people don't know who to go to for certain things, I guess.
I think one of the things that's come out is access to medical information. So someone in the health system can actually work across different systems, so they can actually access the health data and health records. And that has been something. And then, but you know, health hasn't been great at communicating with other healthcare professionals as well. And we know that then we've got, you know, private practitioners where we've got, you know, issues around information sharing. So this is where it's a tricky one, because we really, the MND advisors and the coordinators of support do amazing work in that social, you know, care space. So but they haven't got that access to health medical records. So that is where this complexity. So whether there is someone that opens those doors in the health system and then opens the doors in the social system, and we need somebody that can actually work across them all, really.
Right. Thank you, Karen and Anne. I think we're just running out of time. Sarah, are you gonna wrap up?
Well, thank you so much, Anne and Karen. That was really wonderful to hear. And I think there's some really strong interest from the audience about a lot of the research that you've done. So thank you so much for taking the time to speak to us today. If there's anything anyone else would like to follow up with our speakers today, I'm sure they'd be delighted for you to reach out to them and answer any of their questions. Or if you'd like FightMND to help you connect, we're more than happy to do so as well. So feel free to reach out to us. So thank you everybody for joining us today for the August FightMND Scientific Seminar. We hope you've really enjoyed today's presentation. Please do join us again next month when we will have an exciting new seminar. Keep an eye out in your emails for news on this seminar, which will take place on Tuesday, September 29th at 12 p.m. Australian Eastern Time. Thank you so much. We'll see you next time and have a lovely day.